Bismillah ar-Rahman ar-Rahim. Choroidal neovascular membranes. Choroidal neovascular membranes are new damaging blood vessels that grow beneath the retina. These blood vessels usually grow in the choroid. To a lesser extent, they grow from the retinal plexus. They break through the barrier between the choroid and retina. Then they leak blood or serous fluid in or beneath the retina. Natural history is cicatrization. We have many causes for choroidal neovascular membranes, including degenerative causes, traumatic, inflammatory, dystrophic, others, and idiopathic. By far, the most common is age-related membranes, then degenerative myopathy. We have many causes for choroidal neovascular membrane. Whatever the cause, the pathogenesis is break through the Brach's membrane that allows new vessels to grow from the choroid into subsensory space or vice versa. Three types of neovascular membrane can be identified. Type 1, in which the neovascularization arises between the Brach's membrane and retinal pigment epithelium. The retinal pigment epithelium will be involved in the CNV and elevated upwards, leaving the Brach's membrane, giving the classic double layer appearance. Another example for type 1 choroidal neovascular membrane with typical double layer appearance and elevation of the retinal pigment epithelium. Type 2 neovascularization, in which the neovascular complex arises between the retinal pigment epithelium and subretinal space. We can see the defect in the retinal pigment epithelium and extension of the CNV beneath the sensory retina. In type 3 neovascularization, or what we call RAP, retinal angiomatous proliferation, the new vessels arises from the deep retinal plexus and extends towards the choroid. Management. First, and very important to do, is clinical evaluation. Very important to take a careful history of the patient, know the socioeconomic status of the patient, and know the patient expectations. It is very important to record the best corrected visual acuity, coexisting pathology, and to examine the other eye. Lots of investigation can be used for diagnosis and follow-up of choroidal neovascular membrane, including fluorescein angiography, endocyanine green angiography, optical coherence tomography and optical coherence tomography angiography, fundus autofluorescence, and imaging with color photo, infrared or red-free. Multimodal imaging is very important in detecting the type of the CNV, its etiology, and follow-up its prognosis. For example, this is a case of juxtafoveal telangiectasia type 2, in which the color fundus photography showed in both eyes temporal pallor in the fovea. The left eye shows additional pigmentary changes. Fluorescein angiography shows early faint hyperfluorescence with late staining. OCT shows a typical appearance of type 2 telangiectasia with sciatic changes in the fovea and atrophic changes, irregularities in the temporal foveal architecture. In the left eye, additionally, a hyperreflective tissue can be seen in the temporal area of the fovea. With OCT angiography, the typical telangiectatic appearance of the superficial and deep capillary plexuses can be detected, with right angle angulation of the superficial vessels and marked telangiectasia in the deep one. Additionally, the left eye showed a vascular complex in the avascular zone of the retina. OCT angiography confirmed the presence of secondary CNV in the avascular complex of the retina. A case of chronic central serous chorioretinopathy. However, with color photography, unusual finding was detected, the presence of hard exudate. So, with fluorescein angiography, we could detect a faint retinal pigment epithelial stipple early in the angiogram, which is not rare in central serous chorioretinopathy. However, in the late frame, it takes staining, which indicates that this is an occult or type 1 choroidal neovascular membrane, which extends between the retinal pigment epithelium and Brach's membrane. OCT B scan shows the presence of classic sensory retinal elevation with serous fluid. However, in one of the scans that passes through the stippled fluorescence seen in fluorescein angiography, type 1 choroidal neovascular membrane could be identified. OCT angiography showed the presence of vascular network. However, on adjusting the slab to extend deeper to the retinal pigment epithelium, the extent of the vascular complex was better seen because it is a type 1 choroidal neovascular membrane. But you cannot afford to do all these investigations. Of course, you can use OCT angiography, and it is indeed your best choice. Why? Because it helps you in the diagnosis, detect the type of the CNV, exact type 1, 2, or 3, detect the exact site of the CNV. It plays very important role in the prognosis of the CNV and in the follow-up of the therapy. How could you treat a CNV? First, treatment of choroidal neovascular membrane due to AMD, because they are the most common types of CNV. Prognostic factors. As we discussed before, it is very important to discuss with the patient the prognosis and know the patient expectation. Classically, the prognostic factors included the age of the patient. As the patient becomes older, the prognosis decreases. Size of the CNV, the larger the CNV, the less the prognosis. Site, the more central CNV, the less the prognosis. And best corrected visual acuity. The better the best corrected visual acuity at the start of therapy, the better the prognosis. Recently, OCT added very valuable information regarding the prognosis of the CNV. This information includes the status of the vitreomacular interface. If the vitreomacular interface is intact without complicating epiretinal membranes or vitreomacular traction, it gives you a good prognosis. The choroidal thickness. The thicker the choroid, the better the prognosis. The type of the fluid present. Subretinal fluid or diffuse spongy thickening gives you a better prognosis. Intraretinal cyst and cystic retinal changes, on the other hand, carries less favorable prognosis. OCT angio is a new player that plays an important prognosis of the disease. First, we are going to describe what are the activity signs in CNV as described by Koskas. The shape, a well-defined tortuous vessels, lacy wheel or C-fan shape CNV in contrast to long filamentous type. Branching, numerous tiny capillaries in contrast with large mature vessels. Anastomosis, presence or absence of anastomosis and loops. Morphology of the vessels termini, presence of a peripheral arcades in the contrast to dead tree appearance. Perilesional halo, presence of the perilesional halo, which are hypo-intense in appearance and considered to be a region of choriocapillaris alteration, in contrast to its absence. All these findings gives you better prognosis than the other one. Let's describe this case. It is a case of type 2 choroidal neovascular membrane that show subfoveal extension. However, the overlying retina shows spongy thickening and serous retinal fluid adjacent to it. No vitreomacular interface abnormalities, thick choroid, and normal lacy pattern with OCT angiography, presence of vessels termini. So this membrane carries a more or less favorable prognosis in it. Another case with type 2 choroidal neovascular membrane, spongy retinal thickening, good vitreomacular interface, however relatively thin fluid. OCTA showed a lacy pattern, no non-filamentous appearance, presence of vessels termini and loops, arborization, and presence of perilesional halo, so it carries a favorable prognosis. A disciform scar with outer retinal tubulation, although there is residual fluid, but there is permanent structural damage to the outer fovea, very thin choroid, and filamentous appearance on OCT angiography, so the prognosis in this case is not favorable. Intraretinal large degenerative cyst with disciform scar, minimal intraretinal fluid, filamentous appearance on ACT angiography, so this case carries poor prognosis. What if you encounter a CNV, and this usually seen in the fellow eye of a patient with choroidal neovascular membrane, a starting CNV that is merely elevating the retinal pigment epithelium with very faint vascular plexus starting to grow. What are you going with such case? It's controversial. However, with the recent advances of OCT, you can follow the patient up. And when it is the correct time for treatment, by the correct time we mean the presence of fluid, you can treat. What about the treat and extend and prorata? After the initial loading dose, treat and extend means that you are going to inject not at 4-week interval but at 6 weeks. Then monitor for the disease activity. If no, add 2 weeks, 8 weeks. Then if no activity, add another 2 weeks, 10 weeks. At the point when there is reactivation, start your initial loading dose again, the 3 injection doses, then inject the CNV every 10 weeks, for example. Prorata, on the other hand, means that you are going to inject the 3 loading doses, and perform OCT. When the patient needs injection, by activity we mean the recurrence of fluid and the deterioration of visual acuity. Inject again. Criteria for not to commencing treatment. There are some patients in which you are not going to treat at all. Permanent structural damage in the fovea, where prevention of further visual loss is not possible. Evidence or suspicion of hypersensitivity to a licensed anti-VEGF agent. Such evidence should lead to avoidance of therapy and alternate treatment. When to continue treatment? There is persistent evidence of lesion activity by OCT and deteriorated visual acuity. The lesion continue to respond to repeated treatment. There are no contraindication to continuing treatment. When to discontinue treatment? Reduction of best corrected visual acuity in the treated eye to less than 15 letters on 2 consecutive visits attributable to AMD in the absence of other pathology. Reduction of best corrected visual acuity of 30 letters or more compared to baseline best corrected visual acuity. This may indicate lack of responsiveness to treatment. There is evidence of deterioration of the lesion morphology despite optimum treatment. Enlargement of the scotoma with permanent severe vision loss is almost inevitable if the disease is allowed its natural course. Licensed anti-VEGF treatment will only improve vision in a third of patients. The majority will maintain vision, which is good, and some 10% will not respond to therapy. Again, this is an example of CNV that presented with type 1 CNV with lacy pattern and spongy thickening of the retina. Another kind of CNV with a spongy thickening of the retina, type 2 CNV, lacy pattern and activity angiography, and follow-up after therapy. You can see the absence of fluid, filamentous appearance on ECT angiography, and disease activity. What about B? As we mentioned before, many kinds of CNV are existing. Some are due to trauma, inflammation, dystrophic like Best disease, choroidal scars, idiopathic. The good news is most of these CNV respond well to anti-VEGF therapy. Do not need the initial loading dose. You can inject once and see what are what is the response to treatment, and adjust your therapy accordingly. For a case of myopia, the good news with myopia is a very good response to anti-VEGF therapy as long as the patient is young in age and the CNV is a typical myopic membrane. As the patient becomes older, an overlap in the behavior of the CNV of myopic and age-related CNV becomes evident and more injections are needed. It is very important to detect activity in myopic patients because most of them do not have the normal contour of the fundus, and most of them are very alert about the disease activity. Some of them comes to you even before doing OCT, telling you that they are active again. So multimodal imaging is important, but OCT angiography and OCT hypertrophy is the most important, not the multimodal imaging. Thank you.